So welcome all this afternoon. Conference is going great, fantastic event. It's just wonderful to see the energy and the ideas and the sharing that's going on in the breaks and the meal times. And I hope you're enjoying the chance to spend time with colleagues and swap your ideas and build friendships and relationships. It's my privilege now to introduce you to our next keynote speaker, Dr. Desmond Runyan. And Des, as he's known, is the Jack and Vicky Thompson Professor of Pediatrics at the University of Colorado and the Executive Director of the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. And many of you remember Henry Kemp and his early and pioneering work on raising awareness about child physical abuse. In 1989, Des designed and secured funding for the longest multi-site prospective study of the consequences of child abuse, LongScan. And this study is now 21 years old, and this is a prospective study of 1,354 children in 5 states who are either reported for maltreatment or have been judged to be at very high risk of maltreatment. So a really interesting study, and Des is going to talk to us about the lessons from the long run. I did meet Des just at lunchtime. He told me if he wasn't a doctor and a professor, he may well have been the skipper for commercial liners in the Virgin Islands. That was his backdrop position. But we're glad that you've chose to be a professor, doctor, and to give us this valuable information about the long-term effects of child abuse and neglect. So Des, welcome. If you can join me in welcoming Des.
Thank you very much, Paul. So I did want to have a fallback plan in case medicine didn't work out. But it worked out well enough that I haven't ever gotten back down to the Virgin Islands to be the charter boat skipper I plan to be. Paul told you about the kind of origins of LongScan. I'll go a little bit more into it. I have the daunting task of talking to a group of practitioners about research. And there are probably 2/3 of you that are saying, oh, I hope he doesn't do too much in the way of research. And there's probably 1/3 of you who are doctoral students who are saying, boy, I'm looking forward to the latest in methods. I'm going to disappoint the doctoral students because I kind of oriented this talk more to the practitioners. So let me just tell you about LongScan. The origins of this actually go back to 1974 when the US government formed a thing called the National Center on Child Abuse and Neglect in Washington, D.C. Walter Mondale was a senator from Minnesota and got funding for this center. In 1988, after 14 years, there were some congressional hearings in Washington in which the agency was taken to task. It said, okay, we've given you money for 14 years. What have you discovered? What have you learned? And they challenged the agency had done no substantive work on the origins, the consequences of child abuse, but had frittered away the money on small demonstration projects and sending it off politically to different places. And so the agency, which turns out wasn't very experienced in research, said, all right, we're going to do a longitudinal study. And they put out a request for proposals to plan a longitudinal study. And I thought, well, getting a grant to plan a study is great because normally I plan my studies without any grants, so that sounded good. And then they said, and we're going to fund a study at $130,000 US a year for a longitudinal study to collect data, and we're thinking of a 3-year study. So we took our planning year and said the world doesn't need another 3-year study of child abuse. It needs a 20-year study. And we reserve the right not to do this study if you can't come up with a budget that's reasonable for what's done, and that other federal agencies at that time were funding research at $1,000 per subject per year in prospective studies, and these people were thinking in the order of $10 per subject per year. And so we were a long ways off, but they never did give us the kind of money that the National Institutes of Health would have given us if we had gotten funded by them, but they did make it interesting enough that we went ahead and persevered. We made lots of compromises, and you'll hear some of them today, but I think we generated a pretty interesting data set. So LongScan stands for Longitudinal Studies in Child Abuse and Neglect. We completed the original 20 years, and then we went back and asked for some more money, and their response was, we'll think about it. So in the meantime, we have a grant from the National Institutes of Health to look at the drug abuse of now our participants who are now 24 to 29 years old. There is a website, and a lot of people in our data are publicly available for people who want to analyze LongScan data, and 25 doctoral dissertations have been done across the United States using our data. So the planning grant was funded in 1989, and we spent, it was one of the, actually, I'd seen the movie The Gods Must Be Crazy, And I thought the funding, when they gave us the funding, because they funded us at the University of North Carolina to be the coordinating center, and then they gave us a private nonprofit treatment agency in Chicago as the treatment agency we were to work with, who had no experience collecting data, had no idea how many subjects or kids that they saw per year that might be eligible for the study, and had no research experience. And we were married to them to do the study, and so we were married to them to plan the study. And we spent most of the first year kind of going back and forth. And one of the questions we were trying to ask was, what's the right sample? Do we get a group of children at birth and follow them forward? Do we take a group of children who've been reported and follow them forward? Do we take children who've been substantiated and follow them forward? Or do we take kids who are in foster care and follow them forward? Which is the right sample? Or perhaps to do it better, we might go to a medical center sample that isn't related to the child protection system. And finally, the answer was a yes. We decided to do all of those things. And so LongScan is kind of an interesting amalgamation of lots of different samples. But the children all shared in common is that they were recruited in the first 4 years of life. And we now have seen these children over enough years and followed them forward for enough time that the samples look a lot alike across the cities, because what we know about them is from age 4 to age 18 and 19 is much more than the first 4 years of their life in terms of experiences. The study was mandated by Congress, who had embarrassed the agency by saying you haven't answered the basic questions. It was by an agency that was relatively naive to how to fund research, as I mentioned. They gave the grant to UNC, the University of North Carolina, and to a Juvenile Protective Association of Chicago. And we fought for 9 months to try and come up with a design. We finally came up with one. And so, as I mentioned, the answer to the samples was we would try to do all the samples. We ended up deciding that each site was going to be a study of its own, and each site had to have its own research questions and sample, but that we would merge sites together to answer some questions. That we would have a coordinating center, and all the data would come into the University of North Carolina. We would develop our expertise at North Carolina to do that. One of the problems that child abuse work had in 1989 is that when people were doing studies, they invented their own measures, their own questionnaires, and didn't use standard measures. And so we said, insofar as possible, we're going to adopt standardized measures of outcome that other people have used, or if we develop a new instrument, we're going to make it available to other people in such a way that it can become standardized. And we also wanted to make sure that all the data were coded the same way, the interviewers were trained the same way, and we used a common data entry system to try and minimize variation among sites. And then we became a bureaucracy. We organized for governance, we organized for publications and dissemination, so we did all of those things and had a little constitution. Because ultimately, when you fund with 5 different universities to do this work and another nonprofit agency, there was a lot of individual mistrust that, well, are they going to go publish my data without involving me? And so we had to work out a governance agreement that made sure that every site was represented on every publication, or at least had the right to be represented if they participated in the writing. And so there we had to deal with all the scientific jealousies that can pop up when you have universities collaborating. We had a theoretical model, and I'll point you to the graphic at the top, and the idea is that we're going to measure children at 2-year intervals across the bottom and see how they were doing, and that the extrafamilial environment and the intrafamilial environment were both going to be measured, and we thought that the extrafamilial environment needed a lot of data collection as the kids got older. So that was kind of conceptually what we were looking at. And then we used an ecological models, and there are all the different boxes for all the different parts of the ecology. So where are we now? So the participants are in their 20s. The regional funding ended. Unfortunately, they believed me when I said it was going to be a 20-year study originally, so they stopped the funding after 20 years. But then we went ahead and got another smaller grant that's allowing us to do online data collection for the kids that we can collect. And that's been a little bit of a problem because we're only, of the original 1,354, I think we've got about 400 kids that we've found on social media and the web. And we don't, unfortunately, have enough money to send detectives out to find some of the others. But we're actually hopeful of some additional money to help us do that. The data that we have collected are archived at the Cornell University and made publicly available as part of our agreement with the federal government, and a lot of people have analyzed it. But we've put actually all of our measures are on the web, and our manuals and success and how we score things are on the web, and so other people are using them. And so not only our work, but other work has been informed by this project. So in the fighting of the planning process, we tried to figure out how to do this study. There had been a study that already had 4-year-olds by the time we were getting going. And there was, so that was, the oldest kids were 4 when we started in 1990. And the youngest kids were to be recruited, and we took about 4 years to recruit them. So the youngest kids were, there's almost an 8-year difference between the youngest and oldest kids in the sample. But we interviewed them when everybody at baseline, and then at ages 4, 6, 8. We ran out of money, so we didn't do it at 10. We came back at 12 and 14 and found another bunch of money at 16, and then 18 was the end of the 20 years official funding. And then we reviewed Child Protective Service records to know which children had been reported when, and that was how it was done. It's been a reasonably productive, not as much as it could be, because we actually are a little thin on scientific staff as we've emphasized data collection over and then putting the data publicly, but have about 130 scientific papers, and I'm pleased to say 25 folks have gotten doctoral dissertations out of the project. Our baseline sample was different sites and different samples, and I'll just take you through this slide. On the east, which is the green, we have 282 children who were identified as at risk from a medical center. They were from the inner city pediatric clinics, and I'll break the code and tell you it was the city of Baltimore. And they were either failure to thrive children or drug exposed or HIV exposed in utero. And that was the cohort. The south had 234 children recruited into the sample, and they came from a study that was already in existence called I think it was Stress and Social Support Study. And that was a study in which children were identified in the newborn nursery because the nurses were worried about the families. And they were children who had either were premature with teenage moms or had congenital abnormalities, or the nurses were concerned about the attachment and bonding that the mothers were showing in the newborn nursery. 40% of those children had already been reported to Child Protective Services by age 4. And they were 4 when we started the study, so we took all the children reported to Child Protective Services that we could find, and then matched them with each child that we had been reported with 2 other children from the original cohort that hadn't been reported. So 2/3 of them hadn't been reported, 1/3 had been reported in the North Carolina sample, but that was at risk. The Northwest, when I first started this project, I needed a social service agency that wanted to do research. And I had had enough experience working with social service agencies and trying to do research, and I hope this isn't an appropriate analogy, but when you're up to your ass in alligators, it's hard to remember the goal is to drain the swamp. Maybe I should say crocodiles. And so finding a social service agency that actually wants to take the time and value research was relatively hard. And we looked long and hard, and there basically came 2 choices: Baltimore, and they came into the study in a different way, or Seattle, because Washington State Social Services had a research unit within the agency that had also done research and had its own grants. And so we ended up picking Washington State or Seattle for the group that was reported and not yet investigated. And that was the group that was in the Northwest. They were judged on the risk assessment on the initial encounter to be moderate risk, but the conclusion of the original investigation hadn't been completed. And then there was the JPA, the Juvenile Protective Association, which was a private nonprofit treatment agency that I told you about that didn't know how many children they had and did family therapy, but didn't know how many kids came and went. We worked with them to identify all the other agencies on the north side of Chicago that did the same kind of work. And we selected among that sample families that had been reported, substantiated, and offered treatment with neighborhood controls. And the neighborhood control was another mother living in the same housing complex or building with a child the same age. So that was 2/3 were maltreated, 1/3 were the controls. And then finally, the Southwest, one of the reviewers for the original grant was an investigator who was studying foster care at San Diego State University and had a longitudinal study on foster care already funded by NIMH. And after the grant was awarded, he called me up and said, could we join LongScan? We want to use your measures and we'll collect them and do it the same way. And so John Landsberg and his group in San Diego joined us, and that's how we got the final sample. We were guided by Braffenbrenner and the socio-ecological model. We thought long and hard about how to justify what measures we're using, and this worked pretty well. We wanted to look at the children and the youth themselves, and we wanted to measure them themselves as much as we could in terms of their functioning as well as their characteristics. We wanted to look at the caregivers and their functioning and characteristics. We wanted to look at the home environment and how that was working and what kind of interactions were going on there, whether there's domestic violence, et cetera. And we also wanted to look at the neighborhood and school. So that was the focus of that. And we tried to triangulate measurement to include something that the children would tell us and something we could measure on the children, something the parents would tell us, and some objective records on the parents, et cetera. So we wanted to have multiple sources of data for as many of the variables as possible. Because the funding kind of came through faster than we expected, we didn't actually have the full measurement batteries developed the day we started. So we were developing just in time. We got the 4-year-old interview developed in the first few months, and then suddenly the kids were getting, the process of getting the 6-year-old interview had to start. And then before the 6-year-old interview was very far along, we had to get the 8-year-old. So we had just in time for the first groups of interviews. And we made some mistakes. We used the Center for Epidemiologic Studies depression scale on the mothers, and then for some reason on the age 8 interview, we said, oh, there's this other instrument that we should use. And we switched the instrument to the BSI, a brief symptom inventory. And then later when we were trying to analyze the data and we had the depression scale we used at time 1, time 2, time 6, time 7, and there's this one time that we had used the other instrument. We said, what were we thinking? So there were little lessons learned on that are on the side, not the big lessons, but don't change horses in midstream. And we wanted to do when we started this study in 1990, it was all paper and pencil. And one of the things that we needed to do as science came along and microcomputers came along, and it was to work out a computer-assisted interview process that was more reliable. And so that was done. So we were and we had to develop our own software because we couldn't find any computer-assisted software in the early 90s that would work for long scan. So we had to write our own software to do this. So the lesson 1 is not a big lesson. I think all of you who work in child protection know this. Is the kids that were reported to social services, the kids that were coming into care, didn't look very good at baseline, and I'll show you that. But their development, their cognition, their bipolar disorders, this was a damaged group. So here's a picture of the Patel screener on the development, and you can see that the normal was only 28%. And the others are borderline developmental problems or serious developmental delay, and almost half of them, or more than half of them, were serious developmentally delayed. So this is the and this was not a selected population. This was the kids coming into child welfare with reports or were being reported. We had not intended to get such a handicapped group. In terms of their IQ or cognition, we used the Peabody Picture Vocabulary Test. Only 36% of the kids were functioning on the average range and 2% moderately high. So moderately low or severely low was more than half the sample. So again, not doing so well on the thinking side of things either, or their vocabulary. And these are the child behavior checklist scores. Are all you familiar with the child behavior checklist? This is again a standard instrument worldwide used that basically you get to say whether this is a problem and whether it's a little bit of a problem or a lot of problem, 1 to 3 points. And there's normalized scores. And at age 4 and 6, the children were 66 to 68% were in the normal range on child behavior checklist, but there was a fairly large group that were high on externalizing. Internalizing they looked more normal, but those of you who are familiar with the child behavior checklist, internalizing is depression and anxiety, and outside observers don't always pick that up on kids very well, and we know that teachers and parents aren't always sensitive to internalizing, and the scores, more of them look normal on that scale. And overall, the total problems were about 70% of the kids were functioning okay on behavior problems, and the other 30% were not. And then the Vineland screener was another instrument that was designed to look at their kind of social functioning and how they were doing interacting. And again, the take-home lessons here, and there was actually I actually have a little outcome data on this slide because you can see at age 6, the Vineland screener it's a little hard to see from here. I think it's about 69% were in the normal range in the blue at age 6 on adaptive functioning, and socialization was 65%. And as the kids got older at age 8 and 12, those numbers dropped a little bit, so that in terms of socialization, only 38% of the kids were normal at age 12 in terms of socialization. So one of the problems that one of the first lessons is when you do a study in 5 states, and each state has its own legal definition of what child abuse is in terms of the law, and then you have what practice really is. It turns out that one of the states we're in was my state, North Carolina at the time, and to be diagnosed as psychological maltreatment, or to be recorded as psychological maltreatment in North Carolina requires not only that you have done bad things psychologically to your child, but that you also have not gotten help and refused to get help, and it's a 2-part definition. So basically, kids don't get called psychological maltreatment. And the other thing we discovered is that everybody got called neglect, because state policy in the state of North Carolina is that if you call it abuse, you have to call the police, and that's a dual system investigation, but you didn't have to do that if you called it neglect. And so what ended up happening is 97% of reports are neglect. So we have the highest neglect rate in the country, and we have one of the lowest physical abuse rates in the country. But when we actually survey and find out how people treat their children in terms of harsh discipline, we look just like our neighboring state of South Carolina, which has middle of the country rates for both physical abuse and neglect. So the rules matter. And that is something we had to cope with in this study, because we couldn't look at the long-term outcomes of sexual abuse if, in fact, we were looking at if it was being called neglect instead of sexual abuse. And that was a common pattern. So we had to actually go through and code all of that. The other thing that most maltreatment is a low severity. And so we think in terms of battered children and shaken babies and kids dying, but in fact the majority of, and you know this who work in Child Protective Service know this, most of it is relatively mundane and simple, and or maybe not simple, but mundane and basic, and not nearly as dramatic as blood and broken bones. And then the other thing that we learned is the majority of the maltreatment actually happens in the early years, which was interesting to us, because when you ask parents about what they do to their children, the highest rate of harsh punishment is between 5 and 9 all over the world in terms of what they do to their kids and how for physical punishment. But in terms of who gets reported to the authorities, the majority of kids are reported before age 4. So we used a coding system that is on this slide that describes the different forms of maltreatment. And we ended up creating research categories for each one of these, or research criteria. And it's Barnett, Manley, and Cicchetti, in case any of you researchers here want to look and see what the system, and you can find it on our website. But we coded each record ourselves, and we had a protocol for reading the social services record and making a decision independent of what social services had recorded. We wrote down what they called it, and then we wrote down what we called it on the basis of research definitions to standardize it. And we would record all the different forms of maltreatment, and we would record each with the severity. And so this is an example of long-scan coding for severity for physical abuse. So severity level 1 was no marks. Severity level 2, minor marks. Severity 3, numerous or non-minor marks. Severity level 4 was the emergency room or non-minor marks. 5 was hospitalization for more than 24 hours. And 6 was permanent disability or death. So for each form of maltreatment on our coding system, we came up with a severity code that went between 1 and 6. These are the allegations that Longscan had up through 18 on children. And you can see that the red line is all allegations. The yellow line is, there's 2 yellow lines, sorry. But a blue line is neglect. Green line is emotional abuse, which was we coded instead of using the official social service codes. And I'll come back to that in a minute. And you can see the majority of what happened to our kids happened in the first 6 years of life. And after that, it tapered off. And one of the things I was surprised at was how few of these kids were sexually abused later on, because sexual abuse in the United States, at least, it happens as the kids acquire secondary sex characteristics and happens at a more frequent rate. But our children didn't end up in that category. And in terms of, these are the numbers of substantiation, so the scale changed. So it was 4,000 allegations in the first 4 years down to less than 2,000 substantiations. One of the things that we noted overall in the study was that when we looked at mental health for the children, it didn't matter whether it was substantiated or just an allegation, that the allegation itself predicted the mental health distress. And the substantiations were a distinction without a difference, that we did not do any better job predicting which kids were going to have long-term mental health problems by knowing about substantiation. So we ended up, in all our subsequent papers, we look at our allegations as the exposure for maltreatment, not the substantiations. But one of the things that came up in these data, you can see over here on the slides, that in terms of severity, well, if you'll just take a look at low severity, allegations severity 1 and 2, for physical abuse, that was the most predominant, for neglect and for lack of supervision. So the majority of reports were for the lowest supervision. Only sexual abuse ended up being in the highest severity level, and that was because we defined that in terms of penetration. But you can see that most of everything else. So there's actually a systematic difference in the severity level for sexual abuse that gets the authorities and got to all these samples. And you can see a total of 6,087 reports that this is based on. One of the other lessons from Longscan is you have to ask the children. And I'm going to show you some data that probably won't shock you, but will demonstrate that if you're doing a longitudinal study and you want to know what happens when kids are abused or neglected, you can't rely on social services data to know what happened to them, because social services doesn't know the picture in any perspective compared to what's really happening to kids. So this slide is percent of children were self-reporting physical abuse. We asked the children, we got called out at a national meeting in Longscan because people said, well, how are you going to know about the kids being abused? And said, we're going to review records, and we're reviewing them every 2 years. And our colleagues in the child abuse world all said, well, how come you're not asking the kids? And we said, because we're trying to do a longitudinal study, and if we ask them, they will drop out and not stay in the study, and we won't, our study will fall apart. And they basically, I think the term sledging is used here in cricket. We were sledged by our colleagues around the country in terms of the fact that we didn't have the strength of character or whatever to go ahead and ask the children directly. So we then said, okay, well, if we're going to ask children, what age do we ask them? When is it okay to ask a child about their maltreatment? When can they give informed consent in a research study? Can you ask a child and they understand that if they tell you something and it gets reported to the authorities, their parents might get prosecuted or they might go into foster care. So how do you ask children and do that? So we actually got some money from the National Institutes of Health and ran a conference on directly asking children about maltreatment before we actually started the questioning. And we had 45 people in the room, about half of them researchers and about half non-clinician researchers, like sociologists and non-clinical psychologists, and about half the room was clinical psychologists and pediatricians. And there was almost a complete dichotomy. The clinicians all wanted to report, and the non-clinicians all said it's unethical to report. So we spent 2 days kind of wrestling with that and came out with a special issue of the Journal of Interpersonal Violence that addressed the conclusion. We came to the conclusion that there were research studies that could be done that ethically didn't report kids under certain circumstances that could be done, that children could give informed consent as young as 11. And so that we would, unfortunately our kids weren't yet 11, so we could, in the sledging about not having enough courage to go ahead and ask the kids, we said, well, they're not old enough yet, according to this conference. And so we went ahead and added a computer-assisted interview. The next thing we wanted to do was, how do you ask them in a way that you can make the kids feel secure? And so we ended up coming up with a computer-assisted self-interview with earphones. And they moved a mouse to indicate yes or no to the different questions, and the questions were asked on audio only, on earphones, and so nobody else in the room knew what question they were asking. At the end of the interview, we designed a mechanism by which they could say that they wanted to get help from an interviewer. We basically said, you've told us about some things that have happened to you, would you like us to make sure the interviewer can help you? And then if they said no, we then said, would you like us to make sure that you get help with somebody else helping you? And they could, again, say no, and then they got a third chance. And if they said no on the third chance, the data were encrypted and not available to the authorities, with a couple of exceptions. If they told us about current ongoing sexual abuse, that question couldn't be gone away. Or if it sounded like life-threatening, if they were being beat up or life-threatening physical injuries, they couldn't hide from those. But they could basically keep everything else they told us. They told us about every form of abuse we asked about, somebody in the sample. And not a single child in Longscan wanted the authorities brought in. None of it, they all wanted to keep it confidential. So that was the computer-assisted interview that we did, and at age 12, they told us, this is about self-reporting physical abuse. At age 12, the rates you can see on the scale, but roughly, I think it's about 20% of the children said before age 12 that they had had some physical abuse, and we tried to locate it in terms of before you started elementary school, after elementary school in the last year. And then at age 16, we only asked about the last 4 years to try and fill in the gap. And they actually told us about as much as they told from birth to age 12. And then we asked them again at age 18. We repeated the whole interview lifetime. And here this was interesting because they gave lower numbers than they gave early on for some of the early ones, but birth to age 18, they told us about 44% or 43% of the kids had reported physical abuse. When we compared that to what social services knew, I'll point to the agreement. The red is both social services and the kid said it didn't happen. So this is for physical abuse, you can see, and I'll point to age 18 just to make it simple. 49% of the children said that no physical abuse, and the social service had no record of physical abuse. And there were 6.2% in which they agreed. The kid said, I was physically abused, and social services had a record of physical abuse. There was another 8.2% in which the kids said, no, I've never been physically abused, and social services had a record that they'd been physically abused. And there were 36.6% of the kids, or a third of the kids, told us about physical abuse that social services did not have in their records. So if we were trying to make a long-term assessment of the impact of physical abuse, and we use social service records, we would clearly underrepresent what was going on in physical abuse. And the news was the same for sexual abuse and psychological abuse, and I'll just show these quickly with you. So birth to age 12, about 16% of the kids said that they had been sexually abused, and just a small, about half of that or a little less was in the last year. At age 16, we asked about sexual abuse, and it was another 8 or 9% who had been sexually abused in that time period between, some of the same kids. And then, but interestingly, when we asked them at age 18 for self-reporting sexual abuse, we only came up with a number that was smaller birth to age 18 than the interval time for at age 16 or the age 12 questions. So the kids were telling us a lot less sexual abuse at age 18 than they told us about at 12 and 16. And that's a question that we're actually pursuing in the data to try and see what's different about those kids. And you're saying, yeah, but you have social service records. Well, the data actually don't look very good for social service records either. And I'll just have you turn to the pie diagram that's birth to age 18. We did this when we had 756 of the kids. And you can see that a lot of them agreed that no sexual abuse had occurred. The ones that agreed that sexual abuse had occurred were yellow, and that was 4.6% of the sample. There was some non-disclosure, the color's kind of, but a small amount of non-disclosure, but new reports outnumbered the number of kids that were social services said they had been abused. So we more than doubled the number of children who had been sexually abused. Again, if we were using social service records to know who was exposed to sexual abuse, we would be wrong in a large number of cases. And so it's important to know the self-report data as well. And psychological maltreatment, I'll just quickly point out that over 40% of the children self-reported psychological maltreatment at age 12. The number fell at age 18, but it was still over 35%. This is for a problem that only 3% of Child Protective Service records in the United States officially record psychological maltreatment. And in terms of disagreement, you can see again, almost a third of the children tell us about psychological maltreatment that social services never knew about. So again, if we're looking at the impact, long-term impact, there's no substitute for asking the children directly. Okay, so you can all raise your hands if you've heard of ACEs, or Adverse Childhood Experiences. Okay. It's terminology that was talked about. Vince Folletti is a preventive medicine physician in San Diego who's working with a health plan that had talked about this in adults, and talked about if you have 4 ACEs or more, you're much higher risk for bad outcomes like heart disease and cancer. But our maltreated kids are off the chart in terms of ACEs. I mean, the number of kids that we have, I mean, I'll show you the data, but we have kids with 54 ACEs, and how do you put that in? So when you have kids with 4 ACEs, that's supposed to be predicted. Everybody has 4 ACEs in our sample. I mean, there's nobody that doesn't. But the other thing that's interesting to us, and I think interesting to you, is that when the language and discussion about ACEs doesn't talk about the differential impact at different ages. As a pediatrician, and in our data, I don't go into great length, but At age 4 and 6, witnessing domestic violence seems to have more impact on the kids than being a physical or sexual abuse victim. And that at age 12, being a victim of psychological maltreatment appears to have more impact than physical or sexual abuse. And it isn't until 14 and 16 that physical and sexual abuse explain a greater proportion of the trauma in kids. And so in the ACEs literature, we're supposed to count all these different bad experiences as being the same. But in fact, as a pediatrician, knowing that developmentally what happens when it happened, what has happened and when it happened is different. The ACE literature is a little simplistic. It may be very useful for us to get our National Institutes of Health to pay attention to this problem, but it's actually not very helpful within a child protective service population. And I mentioned in the slide here that 4% of the depression and behavior problems in 4 to 8-year-olds were explained by I guess I left off the domestic violence. I'm sorry, while sexual abuse and neglect explain less than 2% of it. So the domestic violence exposure in young kids is more important. Age 12, psychological victimization explained most of the distress. And it wasn't until 14 and 16 that the greatest amount of distress was explained by the physical and sexual abuse. So the types of life events, the adverse childhood experiences, family transitions, family stress, exposure to violence, illegal justice involvement are all things that are, and this is our slide of what the ACEs look like, our stressful life events in our sample as you go from 2 to 15. And you can see that the darker is the ones that have happened in the last year, but if we added up what's going on, you can see that we're getting up into the 50s for total numbers of stressful life events happening to these kids. So we're blowing the adverse childhood experiences off the chart, and that study, in a sense, doesn't apply to our kids. And this was just a listing of the adverse childhood experiences. We also looked at them the same way Vince Folletti did. We tried to look at physical health and whether adverse childhood experiences explain physical health. And we used these 8 adverse childhood experiences, the psychological, physical, sexual, neglect, alcohol, substance abuse of the caregiver, depression, caregiver being treated violently, and criminal behavior in the household. And our conclusion was that we couldn't predict child's health status on the basis of their ACE exposure at age 12. At age 14, we could explain their somatic complaints, how often but not their actual physical health. And at age 18, we could explain their somatic complaints a little bit better and some small significant difference in terms of physical health, but not very much. But part of it is that the scale is wrong. Our kids have so many adverse experiences that we're not able to look at it the same way. So greater adversities before age 6 were associated with somatic complaints and kind of a non-specific question about poor health. After age 6, child reported poor health, somatic complaints, and there was a small but not really strong association with illness requiring medical attention. The next one we looked at, people were very interested in the foster care, and some of my early work was on the impact of foster care on maltreated children, so we were very interested in that. But it turns out the story is incredibly complicated about foster care. And these kids don't go into foster care because they had a perfect life before they got taken into foster care. And sorting all of that out gets more complicated. We did see in long scan that the kids with more placements had more behavior problems. And we had some interesting issues about, well, how long is a placement? Is respite care for a weekend? Should you count that in the research side? Does that count as a placement, or should that not count as a placement? And making rules about kind of which things to count got complicated. And what if you go back to the same respite care whenever you go, and so it's one other household you're going to as opposed to 7 other households you're going to for respite care? So measurement of foster care exposure was a little complicated. That was one of our lessons, but more placements overall, and we made a rule that if it wasn't for 2 weeks, it didn't count as a placement, to try and to take out the weekend respite care. And more placements meant more behavior problems. Unfortunately, more behavior problems also meant more placements. And so as we tried to tease out the cause and effect, the kids that were blowing out of one foster home were not blowing out of there because the foster home was just being willy-nilly trying to get rid of them. They were solving their problem, which was this child's problems. And when they sexually assaulted a kid in the foster home, they got moved. And so their behavior problems became the family's problems, and they got moved. No big surprise for people in the Child Protective Service system, but when you try and tease out the effects of foster care, it's a lot more complicated. The other thing we found, when the adopted children actually looked the best in terms of what they look like, but the adopted kids had, the adopted parents had far more resources than any other set of parents that these kids could have gone to. So the kin placements or the returning to the home or other out-of-home foster family care didn't look nearly as strong as the adoptive homes, and the kids in adoptive homes did look better. But the solution obviously is not to take every problem household and put the kids into adoptive care. But there were some other interesting issues about it. We had multiple placements. Of the 415 children who were in foster care, they ranged from 2 to 16 placements. And we looked at the change in the child behavior checklist at baseline and then following up. And we also looked at their placements, and we found, as I mentioned, that the average number of placements was 4.23. Number of behavior problems was an accurate predictor of subsequent placements after that. Number of placements predicted behavior problems for those that didn't have them initially. So it's in both directions. We also found that the children who were reunited between 4 and 6 looked better than the kids who were still in foster care in terms of how they were functioning, and they were reunited. 2 years later, the kids who'd been reunited looked worse than the kids who had stayed in foster care. And I guess the answer is they were going home to the home that was, for many of them, that was the problem home that got them into care in the first place. And we perhaps spent too much resources on taking them out of the home and not enough resources on helping the family that was getting them back. So the children who were reunified by age 4, at age 6 had more internalizing problems than the kids who'd stayed in foster care. And reunified kids, however, reported they were more connected to their social environment, they were more connected to peers and adults, and had more supportive people than those who stayed in foster care. So a mixed and complicated picture that, and we're continuing to analyze the data for now as the kids get in 20s to take a look. The kids who were unified, however, ended up being more exposed to intimate partner violence. They went back to the family they came from, and they're more community violence, more caregiver mental health problems, worse family functioning, lower levels of parental support, and more stressful life events. So reunification carried some real risk for our kids when they went home. And the reunified kids, the families were much less likely to ask for mental health services than the foster parents when the kids had behavior problems. So the reunified kids were much less likely to get additional help. The problem was, in our view, was that when the kids went home, the agencies got out of their lives and those kids were kind of left. So then I was going to tell you about a maltreatment's effect on risky sexual behavior. We were interested in this for a variety of reasons, not the least of which is because everybody seems to think sexual abuse is the worst thing that can happen to kids, and they all become sexually acting or damaged or early. And to some extent that's true. We found a lot of early onset of pregnancy, or early onset of sexual, I think the term is sexual debut. But we also found that physical abuse and neglect did those things as well, that this is a kind of final common pathway for the brain that kids who are in trouble do, and so that we found a lot of sexual acting out and sexual risk-taking behavior for kids who are physically abused and who are neglected or abandoned. So early initiation of intercourse at ages 14 and 16 were significantly associated with sexual abuse, but also for all forms of child abuse other than sexual abuse, or sexual abuse and other forms combined. We didn't find gender differences. Those relationships were there for boys and for girls, for sexual abuse, psychological abuse, and neglect. The sexual abuse and the sexual acting out, early onset of sexual activity and physical abuse wasn't quite as strong for boys, but it was for neglect and psychological maltreatment. Lesson 5, the discussion about sexual abuse may or may not be the most destructive form of abuse. I see all the time articles that talk about sexual abuse and treat it as obviously the worst thing that could happen to kids and far worse than physical abuse or neglect. Not to excuse that it's not a serious problem, but it does seem to put blinders on the importance of other forms of maltreatment as well. We get all worked up, and part of it is because as adults, sexuality means something to us, and it has all kinds of connotations. It may not have those connotations for very young kids, and it's just weird stuff being done by an adult, and it may not be nearly as hazardous. So we in fact thought they were all linked to risky behavior, that externalizing behaviors become less prominent over time in all of the kids. They all seem to get better. In internalizing behaviors or internalizing problems, anxiety, depression get to be a bigger issue. I think I'll turn and look at this slide for a while. So we did find the sexual abuse associated with risky behavior and all of the different forms, and we didn't find gender. I guess I said this before. I'm sorry, the slide. This is statistics in terms of how many kids were aggressive at different ages. So looking at the youth self-report in terms of aggression, 7.5% of our maltreated kids, which was 2/3 of the sample, were coded as aggressive. 2.6% of the non-maltreated children, which was about a quarter of the sample, finally at age 18, they were the control kids in the different sites. In terms of delinquency, the rates again were a little bit higher, but not dramatically so and not absent in the other kids. Any criminal substance use was 7% in the non-maltreated, 8.7 at age 14 in the maltreated kids. Any criminal behavior at 16 was almost half the kids who were maltreated, but more than a third of the kids who were not maltreated. So these samples were from kids who had been reported into the system or judged to be at risk, and their outcomes were coming on kind of regardless of the report of abuse or neglect. And serious health problems, about a third of the kids, and only a slight difference between the maltreated and non-maltreated. So one of the important lessons is these kids are in trouble and need our help, and it's not always the things that we count and code as child maltreatment that are affecting them. When we look, this is of the externalizing scores for the entire sample. What we used is the raw child behavior scores, not the standardized T-scores. And just looking, so this is the scale score for externalizing score, and over 11 is kind of in the clinical range. And at age 6, you can see that the sexual abuse kids were more likely to have behavior problems than the Child Protective Service involved kids who didn't have sexual abuse, and then the kids who hadn't been reported for maltreatment yet were down at the bottom. And you can see there was a downward trend on all these externalizing problems over time, but they didn't exactly cross. The kids who had been in the CPS group or the sexual abuse group didn't get down to the range that the normal kids had ever been at. Internalizing scales go up on the sexual abuse and the child physical abuse. And in some ways, that's not a particularly big surprise. Internalizing scales aren't very accurate for young kids. We can't always tell when our kids are depressed or anxious. It's easier to tell when they're being aggressive and acting out, which is what the externalizing score does. But you can see again that sexual abuse actually did explain a greater proportion of the kids having problems on internalizing, externalizing than physical or abuse or neglect. And both were different from the control group. You all know that, that studies have been published that show that there's a relationship between GI disease and prior sexual abuse in adults, looking to see who has irritable bowel syndrome or GI disease. One of our colleagues at the University of North Carolina who'd been involved in that looked to that in our data set to see if there was a relationship, and found that, that sexual abuse was already associated with abdominal pain complaints at age 12 on the child behavior checklist, which has some questions. And that sexual abuse occurred before the abdominal pain or at the same interview visit, not afterwards. So there was already a relationship between abdominal pain and sexual abuse. And youth report ever having been psychologically, physically, sexual abuse significantly associated with abdominal pain and nausea and vomiting on the child behavior checklist. So we're already seeing the seeds of the later disease in kids early in teenage years. Finally, I want to make the point that child abuse doesn't predict mental health issues and that most kids actually look in the normal range later on. This is anxiety and depression scales looking at maltreatment, and this is a trajectory model in which we plotted the maltreated and non-maltreated on a scale that looked at their anxiety and depression. And you can see that there was kind of a normal curve in which more anxiety and depression as the kids got up to 6 and 8, and then as they got to 10 and 12, it dropped off. There was a little difference. The groups are statistically different, but not dramatically so. Another way of putting this is the next slide, and this is the child behavior checklist or youth self-report scores for these children going through. The blue is the normal again. This goes back. And you can see, I told you before, about 2/3 of the kids were in the normal range. Early on, it's 4 and 6. At age 16, it was 70% of kids in the normal range for externalizing. 80% were in the normal range for internalizing, and total problem score was about 75. So the thing that you often don't hear in this discussion about child maltreatment is the 2/3 to 3/4 of the kids that have somehow persevered or gotten by this. And I think what this tells me is that we're not very good at recognizing the strengths and the resilience of the human spirit, and the kids doing pretty well. And we somehow think that maltreatment equals destruction and disease and is permanent. And these kids can persevere and overcome this. And ours was not a treatment study. We collected data on treatment. Parenthetically, we couldn't find any impact of treatment on our kids. We coded lots of different ways and tortured the data and couldn't find the kids who got more treatment looked better. The final lesson I want to share with you was one that was sobering for me, and that's suicide. That 12 to 21% of age 8 maltreated youth expressed suicidal thoughts on our interview. We were the only people they'd ever told that to in many cases. It never occurred to our clinicians at our hospital nor to social services to kind of pursue that line of questioning with kids. It actually was similar at age 16, but we found that witnessing domestic violence was, for the young kids, was actually the strongest predictor, but also that neglect, physical abuse, and residential instability all predicted which kids were going to be suicidal at age 8. Proportions were similar at 16. The difference is that witnessing family violence no longer showed up, but community violence witnessing did show up as a predictor for which kids were suicidal. And this is just a slide that shows you suicidal ideation, and the black is not maltreated. Here, red is any maltreatment. Green is witnessed domestic violence. Blue is residential instability, and maltreatment and witnessing violence together was that over 20% of the kids in that group were expressing suicidal ideation at age 8. When we looked at age 16, physical abuse, almost 20% of the kids who had been physically maltreated reported suicidal ideation. Psychological maltreatment was over 15%. And community violence was a small little blip, and was statistically significant, but not nearly as dramatic. So in conclusion, spending over 20 years of one's life on one study is a little sobering. You get to know your colleagues very well. A lot of the things we found are things that weren't earth-shattering, that they demonstrated things that had been seen or reported in cross-sectional or retrospective studies before, but I think they put some perspective on it. I mean, no one ever told me as I was becoming a child abuse pediatrician that 3/4 of the kids are going to actually look normal later on in life, and that's something that we kind of forget, and social services and the law and the press forgets. There are major lessons about the scope of risk and harm. We have lots of data that we still haven't even tapped. We looked at mentors and important people for these kids and lots of other things to look at. We learned major lessons about how to measure exposure, and I don't think we captured and got it all quite right, but we learned that you have to look a lot of other ways than just capturing social service records. And then we learned, and we've done major work that I'll send you to our website to look at for social capital and its impact on families, on the role that fathers play in protecting children. Turns out that kids with fathers in the home don't look any different when they're young, with or without fathers, but by the time they're 13 and 14, the sexual acting out and drug use is dramatically higher for the kids without fathers for both boys and girls. So that fathers apparently are an acquired taste. So most of our data are still intact. This was always a kind of an underfunded study with a relatively few people doing lots of work very hard, and we're trying to get up with it. But if there are any doctoral students in the room that want to think about using the long scan study, we're happy to help you do that. And I'll stop and take questions.